Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 485 of our pharmacotherapy series, which majors in ischemic and hemorrhagic stroke. The first case reads, PCP, a 65-year-old man, weighing 100 kilograms, with a height of 5 feet 9 inches, is admitted through the emergency department with right-sided weakness. As per report, the patient was last seen well around 8:30 p.m. by his wife. Around 9:15 p.m., the patient's son heard a bump and went upstairs to find his father on the floor. The patient had a slurred speech and had a right facial droop. At this point 911 was called and patient arrived at 9:45 p.m. to emergency department. He regained consciousness by the time he arrived in the emergency department. Both right extremities are flaccid. He is unable to speak, but is capable of understanding instructions, i.e., expressive aphasia. Gross ophthalmologic examination indicates right-sided neglect, that is, inability of his eyes to track to the right or acknowledge the right side of his body. His blood pressure is 165 systolic, 95 diastolic. Other vital signs are normal. Laboratory studies are all within normal limits. So my first question to you reads, what interventions should have been initiated before arrival in the emergency department? Immediate recognition of, and response to, stroke symptoms are essential to an optimal outcome. As soon as stroke symptoms are recognized, the emergency medical system should be activated. Emergency medical personnel should be trained to gather important historical information, especially when the symptoms started. This is defined as, when the patient was at his or her previous baseline or symptom-free state. For patients unable to provide information or who was awakened with stroke symptoms, the time of onset is defined as when the patient was last awake and symptom-free or known to be normal. Use of a standardized evaluation tool such as the Cincinnati Pre-Hospital Stroke Scale or Los Angeles Pre-Hospital Stroke Screen is useful in distinguishing stroke symptoms from other disorders, such as conversion disorder, hypertensive encephalopathy, hypoglycemia, complicated migraine, or seizures. General supportive care for respiratory and cardiovascular function should be initiated before transporting the patient to the emergency department. An important key to effectively managing acute stroke patients is to have a well-designed evaluation and treatment algorithm that addresses assessment and care of the patient from initial onset of symptoms through rehabilitation. Patients with suspected cerebral infarction should be transported, if possible, to the closest certified primary care center. A certified primary care center would have a multidisciplinary team and would be activated and notified by the emergency personnel while potential stroke patient is en route. If a primary stroke center is not locally available, patients can be stabilized in community hospital. In these situations, local providers may use practice arrangements with larger centers that allow the provision of advanced care under the supervision of experts at a primary stroke center. My second question to you reads: what diagnostic tests and evaluations will be helpful in guiding PCP's therapy? Basic laboratory and diagnostic tests should be quickly performed to exclude non-cerebrovascular causes of PCP's symptoms, such as metabolic or toxicologic derangement or infections. These tests include a routine serum chemistry profile, that is electrolytes, blood urea nitrogen, serum creatinine, hepatic enzymes, calcium, phosphorus, magnesium, and albumin, complete blood count, and toxicology screen. Coagulation studies, including a prothrombin time with INR and partial thromboplastin time, should be performed to provide baseline values for potential anticoagulation or thrombolytic therapy. In addition, a thorough physical, neurologic, cardiovascular, and mental status examination should be performed. The neurologic examination will assist in localization of the lesion in the CNS. The physical examination should include use of the National Institutes of Health stroke scale. In addition to providing important information for diagnosis of his neurologic compromise, these tests will provide baseline data for ongoing assessment of PCP's progress and recovery. The etiology of a stroke, ischemic versus hemorrhagic, is difficult to discern based solely on a physical and neurologic examination. As a result, CT or magnetic resonance imaging, abbreviated as MRI, is valuable in the evaluation of these patients. An MRI is preferred to ACT because of its superior tissue contrast, ability to obtain images in multiple planes, absence of artifacts caused by bone, vascular imaging capabilities, absence of ionizing radiation, and safer contrast media. MRI also allows for a magnetic resonance angiogram to be performed, allowing visualization of the cerebrovasculature and possible identification of the precise location of the thrombus or embolus. Within the first 24 hours of an ischemic stroke, an MRI is clearly more sensitive than ACT. After 48 hours, the MRI and CT are equally effective in detecting ischemic infarcts. The primary disadvantages of the MRI are that it is more sensitive to artifacts, more difficult to perform in unstable patients, and not always available in smaller hospitals or communities. In addition, MRI is also not safe to be done in patients who have metallic implants or pacemakers. PCP must have either ACT or an MRI before initiation of any specific therapy for stroke. A follow-up CT or MRI in 5 to 7 days is useful to determine the extent of neurologic damage resulting from the ischemic stroke. Angiographic, Doppler, or sonographic examination of the cerebral vasculature may be helpful in identifying the location of the vascular lesion. These tests usually are performed after the patient has been stabilized, unless angioplasty with stents, mechanical retrieval devices, or use of intra-arterial fibrinolytics is anticipated. A lumbar puncture with collection of CSF for evaluation may be helpful in identifying the presence of blood in the CNS. In the presence of suspected increased intracranial pressure, a lumbar puncture must be avoided because of the potential for tentorial herniation. The next case reads, a head CT revealed left middle cerebral artery territory infarction with no cerebral hemorrhage or edema. So my question to you reads, is PCP a candidate for intravenous thrombolysis? The critical primary event in a thromboembolic stroke is the development of an acute thrombus. Prospective cerebral angiography has demonstrated an arterial occlusion corresponding to the area of acute neurologic deficit in greater than 90% of cases. Occlusion of cerebral arteries does not cause complete ischemia because collateral circulation from other arterial sources provides unstable and incomplete circulation to the ischemic region of the brain. When blood flow is sustained in the range of 10 to 18 milliliters per 100 grams per minute, irreversible cellular damage may occur. Blood flow must be restored quickly after the event. Experimental studies in dogs and cats have shown that when blood flow is restored within 2 to 3 hours, neurologic deficits are prevented. Thrombolytic agents can re-establish blood flow to ischemic regions of the brain. The most important factor in successful thrombolytic therapy is early treatment. The selection of appropriate candidates for thrombolysis is extremely important and requires the correct neurologic evaluation by a specialized team. Before the initiation of thrombolytics, patients with high blood pressure should have their blood pressure lowered carefully to systolic blood pressure below 185 and diastolic blood pressure below 110 mm of mercury. Randomized, controlled trials have shown that intravenous tissue plasminogen activator, all NAPLEX, to be beneficial for select patients with acute ischemic stroke who start treatment within 4.5 hours. For eligible patients once ACT ruled out a hemorrhage, intravenous tissue plasminogen activator should be started within 4.5 hours of clearly defined symptoms. There are specific criteria to select patients for all NAPLEX eligibility if they present within 3 hours of onset of symptoms versus if they present up to 4.5 hours of symptoms. Several thrombolytics, streptokinase, all NAPLEX, tenecteplase, reteplase, urokinase, are available. However, only all NAPLEX trials have shown benefits and improved outcomes. In 3 studies, streptokinase was used as the thrombolytic, and all of these studies were terminated early owing to high rates of mortality and intracranial hemorrhage associated with streptokinase. The rates of intracranial hemorrhage ranged from 6% to 17% for patients receiving streptokinase compared with 0.6% to 3% for patients receiving placebo. The National Institute of Neurological Disorders and Stroke, abbreviated as NINDS, all NAPLEX trial and the European Cooperative Acute Stroke Study, abbreviated as ECASS1, used different doses, inclusion criteria, and treatment protocols. Both trials showed the benefit of all NAPLEX in at least some outcome parameters. In the NINDS all NAPLEX study, patients were enrolled within 3 hours of symptom onset using strict inclusion and exclusion criteria. When enrolled, patients received either all NAPLEX 0.9 mg per kilogram, to a maximal dose of 90 mg, with 10% of the dose given as a bolus for 1 minute and the remainder infused for 60 minutes, or placebo. In this study, there were no differences at 24 hours in responses between the placebo group and those who received all NAPLEX. However, at 3 months, patients who received all NAPLEX were 30% more likely to have minimal or no disability. There was an 11% to 13% absolute increase in the number of patients with excellent outcomes and a corresponding decrease in the number of patients with severe neurologic impairment or death at 3 months. Intracranial hemorrhage occurred more frequently among patients receiving all NAPLEX, that is 6.4%, than in patients receiving placebo, that is 0.6%. Despite the increased incidence of intracranial hemorrhage, outcomes remained better for patients receiving all NAPLEX. For the ECASS-1 trial, patients were enrolled within 6 hours of the onset of symptoms. The treatment protocol consisted of intravenous all NAPLEX 1.1 mg per kilogram, to a maximum dose of 100 mg, or placebo. There was no difference in the primary outcome measures of functionality at 3 months. However, with target population analysis, there was a significant difference favoring all NAPLEX. Of all NAPLEX treated patients, 41% had minimal or no disability compared with 29% of placebo-treated patients. A variety of secondary outcome measures favored all NAPLEX. There was no difference in 30-day mortality rates, but 19.8% of all NAPLEX treated patients had major parenchymal hemorrhages compared with 6.5% of placebo-treated patients. Since NINDS and ECASS-1, 3 subsequent trials, the ECASS-2 and all NAPLEX thrombolysis for acute non-interventional therapy in ischemic stroke, abbreviated as Atlantis A and B, found largely same effects as NINDS when therapy was initiated in the equal to or less than 3-hour time period. The ECASS-2 study used an all NAPLEX dose of 0.9 mg per kilogram and replicated the NINDS trial. However, patients were enrolled up to 6 hours after the onset of stroke symptoms. This study found no difference between all NAPLEX and placebo. Too few patients were enrolled with stroke symptoms within 3 hours to reliably evaluate the influence of this variable on outcome. Since NINDS, several trials have also investigated the use of intravenous all NAPLEX up to 6 hours after stroke onset. ECASS-1, ECASS-2, Atlantis A and B, all enrolled patients with extended window use of all NAPLEX. None of these trials found individually a benefit. However, a pooled analysis suggested improved outcomes. Hence, the ECASS-3 study was conducted to evaluate the efficacy and safety of all NAPLEX administered used the NINDS all NAPLEX dose, that is 0.9 mg per kilogram to a maximum of 90 mg, but it focused on the efficacy and safety of all NAPLEX administered 3 to 4.5 hours after the onset of symptoms. A significantly greater number of patients receiving all NAPLEX had favorable outcomes on the modified Rankin score global disability scale compared with placebo, odds ratio 1.34, with a 95% confidence interval of 1.02 to 1.76. Although the rate of intracranial hemorrhage was greater with all NAPLEX, mortality and reports of adverse events were similar between the two groups. When considering the use of all NAPLEX in the 3 to 4.5 hour window, the ECASS-3 criteria should be followed. A second large randomized placebo-controlled trial was recently published. In this third international stroke trial, abbreviated as IST3, following NINDS dosing scheme for all NAPLEX, patients enrolled with 6 hours of symptoms onset, there was a significant improvement in functional outcome in the Oxford Handicap Score, 0-2, alive and independent, odds ratio 1.27, with a 95% confidence interval 1.1 to 1.47. There were more deaths at 7 days in the all NAPLEX group though. ITS-3 included patients above 80 years of age in comparison to ECASS-3 and a broader blood pressure eligibility. Because PCP presented to the emergency department within 3 hours of the onset of his stroke symptoms, he is a candidate for all NAPLEX therapy in accordance with the NINS study protocol, making sure the patient has no exclusion criteria. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 486.